I'm not that great. So I'm going to basically give an update on sickle cell disease, and my talk is going to focus very much on new advances in sickle cell disease, particularly around our understanding of the pathophysiology and how the pathophysiology of sickle cell disease is actually driving the development of new treatments which are going to really change how we manage patients with sickle cell. So I'm going to cover new insights into the pathophysiology, and then I'm going to talk a little bit about changes in our understanding about HbF modulation, and in particular I'm going to focus on sickle cell stroke and the role of hydroxyurea in those patients. Then I'm going to talk a couple of slides really about novel approaches in bone marrow transplant, and then talk a little bit about the role of gene therapy and why the results of gene therapy trials at the moment are not as promising as we would hope. And then we're going to talk about the new drugs, which are really very important. All in 30 minutes, fingers crossed. So new insights into the pathophysiology. I think understanding pathophysiology of sickle cell disease is really important when you're talking about targeted therapy. And I have to say that, the first patient with sickle was described in 1910 by Henrik. And 100 years later, we were treating our sickle patients in almost the same way: blood transfusion and painkillers. When actually other diseases like chronic myeloid leukemia have been cured because of targeted therapy. And it's all about understanding pathophysiology that can actually drive the cure for these conditions. So early studies have shown that sickle cell red blood cells are important in initiating and propagating vaso-occlusive events. And we know that the post-capillary venules are where the bulk of the trapping of the red blood cells happens. And that is predominantly the site from which the ischemic infarctive process starts. And we know that the sickle cell abnormalities that we see within the cells is a multi-step, multicellular pathway which is driven by inflammatory and adherent leukocytes. And we need to understand what is happening at which step, because that is going to help us develop targeted strategies for the management of sickle cell disease. So the first step in sickle cell disease pathophysiology is understanding the role of the endothelium in activation and adherence of neutrophils, which then promote the development of a sickle cell crisis. So the steps start off with the rolling of neutrophils. So I'm going to basically, I hope the pointer works. Here we go. So the rolling of neutrophils is happening at this step here. And this rolling of neutrophils causes activation of the endothelium by the interaction with selectins on the endothelium. This then results in the role of integrins, which are also active on the endothelium. And these integrins will then cause the activation of the neutrophil and the formation of the MAC1 on the leading edge of the neutrophil. The MAC1 is an integrin which is very important, that we really didn't understand its mechanism until a few years ago. What MAC1 does is that it actually, on the leading edge, will induce the adhesion of sickle cell red cells. And that is how the neutrophil and the sickled red cell interact. This mechanism here in the postcapillary venule is what you will then see where you get vaso-occlusion starting. So this step, the endothelial activation, promoting neutrophil activation of MAC1, and then the adherence of the sickled red cells onto the neutrophil is what actually causes the log jamming effect that we have in sickle cell disease. Inflammation is incredibly important in sickle cell disease, and we know that sickle cell is a pro-inflammatory state, and a lot of very great work has happened in helping identify all of these processes. So the steps really start with the presence of heme in the blood supply. So in the blood vessel you have heme. Heme then causes activation via TLR4, which is this molecule here. This then causes the red blood cells to release PIGF, and PIGF will then activate the monocytes. And these monocytes will promote the release of TNF-alpha. As you can see here, this promotes the release of TNF-alpha. The release of TNF-alpha then causes a cascade of events to happen. So this promotes platelet adhesion on the endothelium. The platelet adhesion on the endothelium will then cause the activation of the endothelium via ICAM, BCAM, P and E-selectin molecules. And this then initiates the recruitment of neutrophils and the activation of the MAC1. So this step here then proceeds to the rolling of the neutrophils and the formation of the neutrophil and the erythrocyte, sickled erythrocyte log jamming effect. The other thing that we know is that invariant natural killer T cells play a role in erythrocyte activation, particularly in the sickle cell inflammatory process. And the invariant natural killer T cells cause activation of these cells and release interferon gamma, and they also release CXCL9 and 10. These two molecules are inflammatory cytokines and chemokines, and these play a very important role in a number of steps in the pathway. One of the main effects that they have is on the formation and the progression of sickle cell respiratory complications, and in particular, the development eventually of pulmonary hypertension. And we know that the CXCL pathway is involved in activation of neutrophils, platelets, and the erythrocytes to form the log jamming effect that we see within the blood vessels and within the sickling crisis as it happens within a patient. So sickle cell is a really complex pathophysiological disorder which has both the effects of inflammation as well as the mechanical activation of vasoocclusion by log jamming with neutrophils and erythrocytes, platelets and monocytes, all playing a role in the pathophysiology. The other thing that we've learned recently is that intravenous immunoglobulins also play a role in vasoocclusion, and in fact, it's thought that these will inhibit vasoocclusion by inhibiting neutrophil adhesion to the endothelium, and this has been shown in sickle cell mice. And there is some data to suggest that via the FGR receptor, we can actually cause a reduction in the MAC1 activity. And as I just spoke to you about MAC1 causing the effect of neutrophil log jamming with the erythrocytes, this is a really potentially exciting target to work on with sickle cell disease. So we're going to jump now because I'm going to talk about new therapies more towards the end, but I do think that hemoglobin F is a very important role player, and some of the drugs that are in development are focusing specifically on hemoglobin F. So what we're going to do is we're talking a little bit about what new insights are with regards our understanding of the role of hydroxyurea in sickle. And I think this paper, the Createl cohort, which looked at patients from over a decade in France, they have a very interesting set of data, I think, which really does warrant some more detailed discussion. Because I think we're really worried about switching patients to hydroxyurea in patients who've got abnormal TCDs. And I think this paper gives us some insight into who would be safe to transfer over, because we cannot really give our sickle patients long-term blood transfusions. So they took their patients who had abnormal TCDs and they gave them transfusions for the vast majority. These patients, only one went to hydroxyurea in that cohort. They waited for these patients to normalize their TCDs over a period of time. And in general, that period of time was in the range of about a year to 2 years at the very least. In the patients who did not normalize their TCDs, they decided in those patients to continue long-term transfusion, or they moved those patients to allogeneic transplantation. So patients who didn't normalize TCDs went ahead with chronic transfusion long-term or went to BMT. In the patients who did normalize, ones who had matched donors, they went ahead with transplantation. A number said, we don't feel comfortable going on to hydroxyurea, and they continued with chronic transfusions. But about half of those patients actually went on to hydroxyurea. Those patients who went on to hydroxyurea got very frequent, very careful monitoring of the TCDs. And in patients where the TCDs remained normal, they continued on hydroxyurea. So out of the 46 patients, 33 showed no reversion and they continued hydroxyurea. In the ones that showed reversion back to an abnormal TCD, they then either went for transplantation or they were on chronic transfusions for a period of time and then went back onto hydroxyurea. The interesting thing about the creatyl cohort is that, number one, it shows that you do reverse TCDs in a significant proportion of patients over time. And the other very interesting thing was the role of MRA. So they looked at patients who had stenosis. And in patients who had stenosis on MRA, those patients, by and large, were the ones who needed long-term transfusion. These patients did not reverse their TCDs. So I think in patients who have abnormal TCDs where we decide to start them off on long-term transfusion, we should, at some point, look at their TCDs and MRAs together in conjunction and identify patients who really should continue long-term transfusion and then think about switching the ones who have normal TCDs and no evidence of stenosis and switching them over safely to hydroxyurea. So the creatyl cohort's a very interesting study and a very interesting population. There's been another very interesting paper about bone marrow transplantation in sickle. We all know the data from the haploidentical transplant study, so I'm not going to talk about those, but I am going to talk about low-intensity conditioning because I think this is really very promising data in this patient set. So this study was published last year, and it looked at non-myeloablative stem cell transplantation using alemtuzumab with low-dose irradiation. So this is a non-myeloablative transplant. And what they actually did, when you look at this data, and I'm very sorry about the small size of the slide, but these patients are a very severe cohort of patients. They had severe sickle cell disease with AVN. Many of them had had recurrent acute chest syndrome crises. Many of them were on long-term transfusion. So they took a very bad cohort of sickle cell. And they gave these patients these transplants. These patients did very well. So the hemoglobins went up, as you would expect in the post-transplant setting. But the really interesting data from this paper, which I think we really didn't think about until now, is this data set. So in this patient population, post-transplant, and these patients had had recurrent chest syndrome and were at very high risk of developing pulmonary hypertension, these patients had an improvement in the FEV1, they had an improvement in the forced vital capacity, and they had an improvement in the left atrial size as well. So a significant reduction in the left atrial size. So going ahead with a myeloablative transplant in the sickle population with very severe disease is very likely to improve their respiratory and cardiovascular outcomes. So this is very promising data, and a non-toxic non-myeloablative transplant really gives hope to a lot of patients. So a quick run through on gene therapy, because I think there are some very interesting things coming out from gene therapy, and certainly at ASH this year there was huge amounts of presentations focused on very early studies both in mice and also more later studies in humans on gene therapy. So there are just a very, very simple point to note that there are 3 different strategies for gene therapy. You can use zinc fingers, and that is basically removal of a gene, so a genectomy. You can use talons, which allow you to insert a portion of a gene, and you can use CRISPR-Cas9. The gene correction using zinc fingers is potentially a very interesting option because it allows for a it allows for a transplant using a universal donor. It doesn't actually need the patient's hematopoietic stem cell to allow that gene therapy to happen. So where are we at the moment with gene therapy? Well, we have a lot of patient hematopoietic stem cells using CRISPR-Cas9 and TALEN techniques, but we also have some interesting data coming out from hematopoietic stem cells using zinc fingers, which is predominantly focused on the use of the hemoglobin F modulation and stimulating the hemoglobin F production in that population of patients. So it's not correcting the sickle gene itself, it's actually causing the promotion of the F gene and allowing hemoglobin F to become the predominant hemoglobin. So there's a number of strategies for promoting hemoglobin F. There is the gamma globin reactivation, which is basically you're forcing the expression of the gamma globin gene and forcing the DNA to start making HbF. And you can use that using a couple of techniques, forced expression using forced looping, and you can also use specific activators. And then there is gamma globin de-repression, where you remove the repressor genes which are actually causing downregulation of the hemoglobin F gene after birth. So those are both very interesting strategies, and there's some really interesting data on mice that was presented at ASH showing how this effect may very well be a very suitable option in patients with sickle cell disease. So what we have at the moment with gene therapy is that we do have challenges about delivery and correction of the sickle cell gene itself. And I'm going to show you data from the HGB-206 study, which I was really disappointed to see at ASH because I was hoping it would be more positive. All the patients successfully engrafted with the lentiglobin drug product, which is the same product as is being used in the thalassemia studies. Toxicity profile, everything the same, nothing unsurprising there. The real disappointment is that the vector copy was either very, very low or undetectable at very low titers in some of the patients. The positive is that 4 of the patients had had fewer vaso-occlusive crises. But if you look at the data on the hemoglobin change in these patients and the viral copy number, it's really low. And this is the hemoglobin levels. It's very disappointing in this cohort of patients. And this is really in stark contrast to the data from the 205 study, where they did one sickle cell patient who had been on long-term hypertransfusion for their sickle cell disease. And that patient had a hemoglobin rise of 6 grams and predominantly now transfusion independent. The majority of the sickle hemoglobin has gone and the bulk of it is hemoglobin A. So the stark contrast using the same drug product in the 2 different studies, the 205 versus the 206, is the fact that the patient in the 205 study was hypertransfused prior to transplant. That patient's suppression of endogenous erythropoiesis is probably the reason why that patient did very well, and probably the reason why the patients in the 205 study who were not heavily pre-transfused have not done so well. So I think that there are now currently changes in the protocol that are being used for the gene therapy ongoing clinical trials, and hopefully we should start to see results which are similar to the 205 study. So, drug development in sickle cell disease. We've spoken a bit about the pathophysiology. There are a huge number of studies underway in sickle cell disease, particularly IVIG, SEG1, which is now a published study. I'm going to talk about the phosphodiesterase 9 inhibitor. I'm not going to talk about the antiplatelet drugs because I personally don't think they're that exciting from the data point of view. And we're going to cover mainly the drugs which are really looking very promising. So PF044743, or the phosphodiesterase agent, is a selective GMP inhibitor of phosphodiesterase 9. And in addition to its action by increasing hemoglobin F, hydroxycarbamide, we know, also has an action on nitric oxide. And it acts via the cyclic GMP pathway, and that's why it's thought that the phosphodiesterase 9 is going to be a useful drug. So what has happened with this drug is that in sickle mice, when you use phosphodiesterase 9 with hydroxyurea, you had decreased leukocyte recruitment and decreased rolling of the neutrophils. You had decreased neutrophil and hemoglobin SS interaction, and this was because of suppression of P and E-selectin and decrease in MAC1. So it's acting on all 4 steps of the pathway that we know is involved in activation of neutrophils. So potentially very, very promising drug. So currently the study is looking at 28-day treatment. This is a phase 1b study in patients using BD dosing in patients on hydroxyurea. And the key endpoint with this study is to really predominantly select and get pharmacokinetic and safety data before this goes to a phase 2 study. But this potentially is going to be a very exciting future phase 2 study in patients with sickle cell disease. Other drugs are acting on HbS polymerization, and I'm going to talk about GB044 for this. And basically, a drug that increases the oxyhemoglobin is going to act as an inhibitor of HbS polymerization, so it will stop the formation of sickle cell crystals. And this will allow more oxyhemoglobin to be carried by the sickle hemoglobin, and therefore you should get less hemolysis as a cause of that. So the GBT440 drug is a small molecule that increases hemoglobin oxygen affinity. It's given orally, which is obviously a very good thing, and its primary mechanism of action is by inhibition of S polymerization and therefore increasing hemoglobin affinity for oxygen. So there's some concern about that, because if you bind oxygen tightly, you may decrease the oxygen release to the peripheral tissue. So that is obviously a worry, but what we see in the studies is that there's about 20 to 30% of the hemoglobin S needs to be modified, and that means that we would expect not much change in the oxygen movement to the peripheral tissues, because the oxygen dissociation curve shifts to the left. We see this in hemoglobin sickle with HPFH, where the oxygen dissociation curve, instead of being right shifted, is left shifted. And these patients have a slightly higher hemoglobin and they have a mild erythrocytosis. So the phase 1 study with GBT440 has actually shown, and this is early data, 6-month data in this cohort, and what you can see is that in the majority of the patients given the larger dose, the 900 milligram dose, there's been a rise in the hemoglobin, which is very good. And what's really interesting is that this drug has caused a reduction in the bilirubin, so a reduction in the hemolysis, a reduction in the degree of erythropoietic stress because the hemoglobin is higher, so the reticulocyte count has actually reduced, and the irreversibly sickled cells that are seen on the peripheral blood film have also reduced because the sickle cells are carrying hemoglobin which is more oxygenated. And as a result of this, certainly the hematological markers showing severity of disease have improved in those patients. The long-term dosing really shows a very favorable safety profile, and it's definitely shown a reduction in the hemolysis in those patients. And this is really now moving very quickly towards a phase 3 study, which is going to be called the HOPE study for sickle cell patients. And that's going to really focus on improvement of the hematological parameters and reduction in sickling episodes. N-acetylcysteine has been around for a very long time. It's a cheap drug. We've used it for many years, not in sickle cell disease, but for other conditions. And this drug really works as an antioxidant therapy, and currently it's in phase 2 clinical trial looking at reducing the glutathione levels and decreasing the vaso-occlusive episodes in patients with sickle cell, and it's now in phase 3. Personally, I think that the data on the N-acetylcysteine is not as promising from what I've seen at the ASH meeting in December. So now on to the last set of drugs that I'm going to talk about, which is the P-selectin, which has been published late last year, early this year, and was presented at ASH at the plenary lecture there. So we're going to talk about the SUSTAIN study, which is a placebo-controlled, double-blind, randomized study using Cell-G1 with or without hydroxyurea therapy in patients with sickle cell disease. And this is really very interesting and potentially and hopefully a very exciting new advance in treatment for sickle cell disease. So SELG1 is a P-selectin antibody, humanized P-selectin antibody And if you remember when I was talking about cell adhesion and the neutrophil adhesion, it needs P and E selectins to actually cause the activation process to happen. So the P-selectin is an adhesion molecule that is expressed on activated vascular endothelium and also on platelets, and is a very key molecule involved in initiation of the rolling of the neutrophil and therefore leading to the activation of the MAC1. So upregulation of P-selectin is involved in the interactions between the sickled red cell and the neutrophil. So the SUSTAIN trial looked at 2 doses and compared it to placebo, and the doses were 2.5 versus 5 milligrams per kilogram, and it was given as an IV infusion every 4 weeks for a year, and all genotypes were included in the study, and the endpoint was the annual rate of sickle cell pain crisis. So what you can see from this basic set of data from the study is that it had a highly significant effect on the rate of annual pain crisis, and median time to first pain crisis was significantly reduced. And also there was a reduction in the annual complicated rate. So the severe sickle cell crisis, the life-threatening sickle cell crises appear to have a trend towards reduction. And what you can see is that there's a dose effect. So the higher dose has a more effective reduction in the time to sickle cell event. And also the time to subsequent sickle cell events went down, but it was very similar with both doses. But the higher dose had a predominant effect in reducing the time to the first event, which is the red curve there. So the results and the conclusions from the SUSTAIN study were that this drug is really well tolerated with relatively little by way of severe effects. Arthralgia, pruritus, a bit of vomiting were the main side effects that were seen, and the P-selectin inhibitor had a significant reduction in the sickle cell pain crisis events and was well tolerated. And there was a decrease in the time to first event and a decrease in the time to the second event. So this is potentially a really useful prophylactic therapy for patients with severe sickle cell disease. So sickle cell anemia is finally, I think, really getting the recognition and the attention it deserves. And there are a huge number of drugs that are currently in phase 2-3 drug development, including anticoagulants and novel disease-modifying therapies. And gene therapy, I think, really does offer the potential for cure for these patients. And in the meantime, we have really promising data from the non-myeloablative transplants and the haploidentical transplant setting. So I think that patients with very severe disease really do have a lot to look forward to from the point of view of how we're going to manage their sickle cell disease in the future. So I just want to say thank you for inviting me, and thank you very much for listening patiently. Thank you.
Thank you very, very much, Professor Dr. Shah, for your very interesting and very updated knowledge and presentation on sickle cell disease. Thank you very, very much. I think now there is a coffee break. You can go to the coffee break, and exactly after half an hour, you are invited here to have a very interesting session, started by the very interesting and very updated gene therapy in thalassemia.